Hi, I'm Tricia Ward from the Heart.org and Medscape Cardiology, and I'm here at the ESC in London, and I'm joined today by Dr. Scott Garrison. He is a professor in the Department of Family Medicine at the University of Alberta and director of the Pragmatic Trials Collaborative. Welcome, Dr. Garrison.
Thank you. Happy to be here.
So you presented two studies here today at ESC, and one is the BedMed study comparing day versus nighttime dosing of blood pressure therapy. Can you tell us the top-line findings?
Yeah, we were looking to validate an earlier study that had suggested a large benefit taking blood pressure medication at bedtime as far as reducing major adverse cardiovascular events. That was the MAPEC study. They suggested a 61% reduction. The BedMed trial was in hypertensive primary care patients in 5 Canadian provinces. We randomized well over 3,000 patients to bedtime or morning medications. We looked at major adverse cardiovascular events, so all-cause death or hospitalization or ED visits for acute coronary syndrome, stroke, or heart failure, and a bunch of safety outcomes. And essentially we found that it made absolutely no difference to MACE, to cardiovascular events, whatever time of day you took it, and neither did it make any difference to the adverse effects that we were looking for. It was safe to take it at bedtime, but it did not convey any extra cardiovascular benefit.
And then you did a second study called BedMed-Frail. Do you want to tell us the reasoning for that?
Yeah, so BedMed-Frail took place in a nursing home population, and we had believed that it was possible that frail older adults might have very different risks and benefits, and that they would likely be underrepresented, as they normally are, in the main primary care trial. And in particular, because bedtime blood pressure medications would be theoretically preferentially lowering overnight pressure, which is already the lowest pressure of the day. So you're reaching new lows of blood pressure. That if you were at risk for hypertensive or ischemic adverse events, that might make it worse. So we looked in them at falls and fractures. We looked at worsening of cognition in case they had vascular dementia. We looked at whether they developed decubitus ulcers, so pressure sores. You need a certain amount of pressure to get past the obstruction. In this case is just the weight of your body if you're lying in bed all the time.
That's ours.
We also looked at problem behaviors. So in nursing homes, people who have dementia often have what's called sundowning, where your agitation, your confusion is worse as the evening is going on. On the off chance that had anything to do with blood pressures being lower, as they are at the same time. So we wanted to look and see if problem behaviors were any different. And BedMed-Frail results mirror BedMed exactly. So there was no cardiovascular benefit. In this population, it was largely driven by mortality. I mean, a third of these people died every year.
So the median age was what, about 88?
The median age was 88, yeah. So there was no cardiovascular or mortality advantage to bedtime meds, but neither was there any signal of safety concerns.
And these two studies then mirror the time study that was also...
Yeah, we found pretty much exactly what time had found. Our point estimate was pretty much the same. The hazard ratio in the main trial was 0.96. Theirs, I believe, was 0.95. So yeah, I mean, we agree completely with time and differ substantially from the previous trials that suggested a large benefit.
And those previous trials were MAPEC and HYGEA.
Yeah, so MAPEC was the first one. And then while we were doing our trial, while Time was doing their trial, both trying to validate MAPEC, the same group published another study called HYGEA, which also reported a large reduction, a 45% reduction in MACE.
And then now, you didn't present it, but there was also a meta-analysis presented here by somebody independent of you.
Yes, yes. Ricky Turgeon. Well, I know Ricky. We gave him data, patient level data for his meta-analysis, but I was not otherwise involved in it.
And the conclusions of his meta-analysis?
Is the same. He only found the same 5 trials, right? MAPEC, HYGEA, TIME, BedMed, BedMed-Frail. Combining them all together, the confidence intervals still span 1, so it didn't end up being significant. But he also analyzed TIME, BedMed, BedMed-Frail separately, again, suggesting that those trials showed no benefit. Yeah.
So there was a TIME sub-study of night owls versus early risers, I suppose, or morning people. And that was a hint, or whatever you would say, of a sub-analysis of a neutral trial, that there might be a difference there? Does that?
Yeah, so they recently, I think it was just in the last 2 months, they had published another, I don't know, so really a sub-study. I guess it is sort of a sub-study, but they had looked at people's chronotype according to, did you consider yourself an early bird or a night owl? It was more detailed in their assessment. And they had reported that if people were tending towards being early birds, if they took their blood pressure medicine in the morning, or if they were night owls and they took it in the evening, that they tended to have better, or they statistically significantly had better outcomes than the opposite. Right? In that case, they were only looking at non-fatal MI and non-fatal stroke. So we did ask something which was related. We did ask people, do you naturally consider yourself more of an early bird or a night owl? So we did have that data. For what I presented today, we just looked at the primary outcome, and we did subgroups according to early bird, night owl, or neither. That was not statistically significant. It didn't rule it out. I mean, there were some sort of trends in the direction that they were suggesting, but we do intend to do a closer look at that. But they call these late-breaking trials, and it really was in our case. We didn't get the last of our data from the last province that was giving us data until the end of June. So we still are finishing up the analysis on the chronotype portion of it. So more to come.
More to come about one.
In another, another month or so.
And for the purposes of people to take up, this is mostly about a once daily dosing antihypertensives, or a bit of a mix?
Yeah, it was essentially once daily medicines that were changed for the most part. So the docs did have the opportunity to consolidate twice daily meds into once daily or switch to a different medication. That's probably the area where adherence was the biggest issue, because it's largely beta blockers, and beta blockers that were twice daily at baseline, they were less likely to want to change. But we had, at 6 months, 83% of once daily medications were taken per allocation in the bedtime group, and 95% per allocation in the morning group, which is actually pretty good. And it was very good for ACEs, for ARBs, and for calcium channel blockers. The adherence was excellent. It was beta blockers taken twice a day where it fell down, and then also diuretics. But if you combine all diuretic medications, pure diuretics and combo agents, still 75% of them were successfully taken at bedtime. Only 15% of people switching a diuretic to bedtime actually had problems with nocturia. So most physicians think that they can't do it, and you can. There's probably no reason to take it at bedtime, but most people do tolerate it at bedtime. And
so that's the next question then, is your advice, take it whenever you feel like. I know when TIME came out, Professor George Sturgio, who's going to be the upcoming president of the International Society of Hypertension, he was saying, well, maybe we should stick with the morning, because that's what most of the trials did.
Yeah, I think that's a perfectly valid point of view to say that. I would, and maybe for a lot of people that could be the default. But I think there are some people though who will have a particular reason why one time is better. So for instance, calcium channel blockers, I mean, most people have no problems with them, but sometimes you get ankle swelling, and you're more likely to have that happen if you take it in the morning than if you take it at bedtime. So someone like that might want to take it at bedtime. Or a lot of times people want to take their pills all at the same time if they can. So I would say blood pressure pills are easy ones to switch the timing of if you're trying to accomplish that, and if that would help with adherence. So basically, I think if, whatever time of day you can remember to take it, the best is probably the right time. But I also, what Dr. Sturgio said also has lots of value, I think.
And so, given where we are today with your trial and time, do you think this is now settled science that it doesn't really make a difference?
I'm probably the wrong person to ask because I clearly have a bias. I think the methods in the time trial are really transparent and solid. I hope when our papers come out, people will feel the same. But I think you're just going to have to, look at the different trials and so you need people like Dr. Sturgio to wade through the trials and help you with that. Yeah.
Okay, well, thank you very much for joining me today and discussing this trial.
My pleasure.
So this is Tricia Ward signing off for the Heart.org Medscape Cardiology.